So these are my disclosures. So treatment strategies has been a long and winding road. So we've started from triple therapy. We tried a number of different things during history, like structured treatment interruptions, mega hard, but then, which things that were not working very well. And then we have always wanted to simplify therapy. As you can see here, one of the issues that we tried was monotherapy, which is really something that we should not try anymore. Nowadays, most of our interest is in seeing whether we can use dual therapy instead of triple therapy, because as you will see, there's very interesting data suggesting that possibly in combination with 3TC we would be able to do that. Also, in the future, we will be seeing non-daily regimens and also long-acting or extended release regimens. It is interesting that patients are really interested in simplifying therapy. They are aware that treatment is, so far, it's forever. So they're interested in different types of treatment simplification. For example, here you can see that many patients would be interested in single pills every week, for example, 2 shots in the clinic every other month, or 2 small plastic implants. So why do we want to reduce the drug burden? So there are many reasons to do that. First of all is to make the antiretroviral treatment safer without sacrificing virologic control. Also to improve patient adherence, quality of life, reduce drug-drug interactions, reduce cost sometimes, and also increase the potential for longer-term success, and also to spare classes on the first-line regimen failure. However, using less drugs might also come with some risks. For example, we always have to put on a balance whether with the new less drugs, we would be reducing the potency of our regimes, whether there is less forgiveness for missing doses, maybe there's less penetration in sanctuaries, maybe we need more frequent virological monitoring. Perhaps these treatments will be less durable over time. Also, we know that some drugs have certain properties that are valuable for the clinic. For example, if we withdraw tenofovir, we will be losing a certain amount of the lipid-lowering effect. And also, some of withdrawing certain drugs might be contraindicated in hepatitis B co-infection. So this is not new. It has been a number of different combinations have been tried. There have been a lot of studies looking at treatment simplifications. And to make a long story short, most trials between 1994 and 2013 essentially failed or were not able to achieve good enough responses. However, in 2014, we had Dr. Pedro Can showed the first proof that combining PIs with 3TC in the Gardel and later in the Andes studies would be an option, would achieve at least non-inferiority and in some cases superiority to triple drug therapies. And since 2017, we have started witnessing treatments combining dolutegravir and 3TC, also starting with the pilot studies from Pedro Can, the PADL study, and later the ACTG 5353 study. And following these pilot data, the Gemini 1 and Gemini 2 studies, which have been recently completed, have provided further proof that this is a strategy that could be possible. So, as I was mentioning, initial studies combining lopinavir and efavirenz, but also atazanavir, efavirenz, lopinavir, and nevirapine had good virological response, but increased rate of side effects. A number of other options did not work well. So combining, for example, the darunavir with maraviroc or the darunavir with atazanavir with raltegravir, for example, did not work well. But as I was saying, this is the data from the Gardel study, in which, for the first time, you could see how dual therapy with lopinavir and 3TC was able to achieve comparable virologic suppression to triple therapy with lopinavir, if not better. And also, in the subgroup of patients with more than 100,000 copies at baseline, the effect was even more evident. So boosted PIs are one of the options for initial and maintenance therapy with different results here, as you can see. So, for example, in the NEED study, the Runavir with raltegravir showed similar efficacy as the Runavir-Ritonavir with FTC-TDF, but poor efficacy in patients with high HIV RNA, low CD4 counts, etc. Overall, in this review, systematic review of different PI plus raltegravir studies compared with PI plus 2 and RTIs, in general, overall, this combination was always favoring, these studies were always favoring 3-drug therapy over double therapy with PIs. Lamivudine, however, is a very interesting drug. It is only, it can be given on once daily, and RTI, it is very well tolerated. It has almost no side effects. It has no drug-drug interactions. It is nowadays generic, at least in Europe, with low cost. It has low genetic barrier. It selects for M184V or M184I, but it provides residual antiviral activity even after selecting for the mutation. It has an effect on survival in the presence of M184V, like studies in Italy showed. And also M184V enhances antiviral activity of tenofovir and azidovidine. Therefore, a number of studies have, since dolutegravir has become available, have suggested to combine dolutegravir with 3TC or dolutegravir with rilpivirine, with PIs, etc., etc. This is here on the left-hand side. You can see the first proof of concept that dolutegravir 3TC might be actually a good combination to start therapy with in certain patients, and this is from the PADL study, in which you can see that patients, up to 20 patients started on this combination, achieved full virological suppression. These data were essentially replicated in the ACTG 5353 clinical trial. However, in this clinical trial, there was only one patient that actually, with very low adherence to therapy, who achieved virological failure to dolutegravir 3TC with selection of M184V and 263K mutation. So this can happen. This is something we need to be aware of, but it only has happened in clinical trials once. Most of the evidence, the strongest evidence we have of the potency of dolutegravir and 3TC comes from the Gemini 1 and Gemini 2 clinical trials that were recently completed up to 96 weeks. In these studies, these were two identically designed, randomized, double-blind, parallel group, multicenter non-inferiority studies where antiretroviral naive adults were randomized to receive dolutegravir 3TC versus dolutegravir plus tenofovir FTC. You can see here that these were really large studies with 700 patients per arm, so we are talking about 1,400 patients. After 144 weeks of first double-blind and then open-label phase, patients were allowed to continue with dolutegravir 3TC. About 20% of individuals had more than 100,000 copies when they got in, and about 10% had less than 200 CD4 T cell counts. And here you can see the main efficacy results. Essentially, the two treatment combinations, the two options performed equally well, with very rapid suppression of virological replication and maintenance of suppression of virological replication in more than 90% of patients, or nearly 90% of patients, up to 96 weeks. These were so the non-inferiority criteria were met in the Gemini 1, Gemini 2, but also in the pooled analysis. Similar findings were found for the treatment discontinuation equals failure analysis, which was a pre-planned analysis accounting for confirmed virological withdrawals, and so the same results were found. Time to viral suppression, one could have thought that maybe using 2 drugs would have led to slower time to viral suppression, but that was not the case. So 2 drugs led to suppression of viral replication as fast as 3 drugs. You have to know that here patients did not have M184V or did not have any resistance mutation when they got in. But regardless of whether all patients or patients with even high viral loads, you can see that the time to virological suppression was equal in both treatment arms. This is another way of seeing the data, so very fast decline and persistent suppression of virological suppression. There were very few treatment-defined virological failures. So in total, 11, in the pooled analysis, 11 individuals here and 7 individuals here. There was 0 resistance, which is emerging. So if there had been resistance, we might have been worried a lot if these patients had failed with resistance, but this is a second aspect of a second conclusion of these studies, that patients do well, but also when they fail, even though it is very rare that they fail, but when they fail, they do not seem to select for resistance, at least in this very large study. The proportion, when we analyzed by subgroups, the proportion of individuals with less than 50 copies was similar regardless of whether they had less than 1,000 or more than 1,000 viral load copy numbers at baseline. And as you can see here, only when individuals had more than 500,000 copies at baseline, there was higher rates of virological suppression with triple therapy compared with dual therapy. This has led some guidelines so far, although the numbers are small. See, it's 9 out of 13 versus 12 out of 15. But nevertheless, the EX guidelines and a number of guidelines have added some warnings saying that maybe this dual therapy could not be or should not be as recommended in patients with higher than 500,000 copies per ml at baseline. Nevertheless, when one looks at what happened to these individuals, essentially most individuals achieved virological suppression, and then 1, 2, and 3 patients had no virological data at the time of analysis. So only 1 individual had actually virological failure among these individuals. When a second aspect of a second, So a second point of discussion is what happens with people with less than 200 CD4 counts at baseline. So in these individuals, if one looks at the primary analysis, at the snapshot analysis, individuals with dual therapy have lower rates of virological suppression. However, with the treatment TRDF analysis, the rates are similar, but given that this was the pre-planned primary analysis, to date, we still consider that individuals that dual therapy might underperform in the individuals with less than 200 CD4 counts at baseline. Nevertheless, when one analyzes what happened to these individuals, you can see that virological failure in these subjects was also very rare. So there is a discussion of whether this remark should be added or not into the guidelines. So far, guidelines are being conservative and are suggesting that dual therapy might not be as ideal as triple therapy in patients with less than 200 CD4 T cell counts. However, proper prospective studies are needed, and the situation perhaps might change in the future as more data accumulates. Also, the rates of virological suppression were very similar for different races here, so African heritage, Asian, white, and others. Also in different age ranges, females and males, and also by different hepatitis C serostatus and HIV subtype. Another way of looking at the data is by looking at time to non-detectable. This is a certain characteristic of the viral load. So we can define both if a viral load measurement is below a certain threshold, but also if we can detect it or not. And the company also did this analysis and showing that time to target non-detectable was similar to both groups. Also in subjects with overall, but also in subjects with high, more and less than 100 copies per ml at baseline. Also, the number of blips was not higher in individuals with dual therapy. Actually, there were slightly more blips in the triple therapy arm at week 12 and week 24, but as you can see, the number of blips remained stable was comparable in both arms. In terms of drug-related adverse events, the adverse events profiles were similar, and actually the increased weight was only reported in 2% of participants treated with dolutegravir 3TC and 1.5 in individuals with triple therapy. So we don't see increases in weight in these studies. These studies are performed essentially not necessarily performed in Southern African women, okay? So they include mostly men, so we'll have to see. In terms of renal biomarkers, the truth is that changes the magnitudes of changes are very small, but in any sense, the change in renal biomarkers favors dolutegravir and 3TC, similar to bone biomarkers, but the changes in serum lipids actually favor the triple therapy arm, again, with magnitudes of effect which are very, very, very small. So in summary, for dolutegravir 3TC at 96 weeks compared with triple therapy, we can say that this strategy is durable, achieves non-inferior efficacy, including several subgroup analyses. It is very important that there are no resistance mutations emerging among individuals with confirmed virological failure per protocol. It is possible, so it is possible because the HCTG 5353 study has shown us one individual, but in this extremely large study, this has not been seen. Both arms achieve similar responses using all the parameters that are available to analyze this, so target non-detectable. Also, they have similar incidence of blips, and they seem to have a slightly lower risk of drug-related adverse events. It is a cost-effective option for a substantial proportion of antiretroviral naive patients, at least in Spain. This is an option that many managers, hospital managers are considering, and there will be some push for this. However, you have to keep in mind that the individuals here did not have M184V when they got into the study. So, and that will be one issue. So it seems that this small study published in G8 by Constant Benson and by Femi Taiwo and colleagues, the frequency of genital HIV RNA shedding while virologically suppressing blood was similar between both arms. So it does not seem that dolu3TC is associated with higher genital shedding. So this small study suggests that also this strategy is useful to controlling genital HIV shedding. So as I was mentioning, these results have led the EX guidelines, the latest update in the EX guidelines, to include dolutegravir 3TC among the recommended regimens. It is not the preferred one, and I like the way the EX solved this issue because I think it was very clever. So they listed a number of recommended regimens, and then a few of them were highlighted as preferred. It is not preferred, but it's recommended, and it has to be in people without hepatitis B, with less than 500 copies per ml and more than 200 CD4 T cell counts per microliter, among other options. So this is a dolutegravir 3TC naive patients. So what happens? So the TANGO study provided evidence on using this strategy as a switch. So here we had adults who were virologically suppressed with less than 50 copies per ml for more than 6 months, and they were on a stable TAF regimen. And they were essentially randomized 1-to-1 to switch to dolutegravir 3TC or to remain on their TAF-based regimen. Again, there was no prior virological failure. Sorry. No prior virological failure and no documented NRTI or INSTI resistance. The primary endpoint was at week 48, but the study continued up to week 96, and it's continuing over. In terms of virological outcomes, so the long story short is that both strategies perform exactly equally well. So there are almost no virological failures in any of the two arms, which tells us about how well the study was followed and pursued. This might not be rates that we might find in the clinic, but almost zero virological failures, and the two strategies were equally potent in terms of virological outcomes. These are the data on the snapshot outcome at week 48. So more than 92% of patients undetectable, and again, there were no resistance mutations emerging in the one case only of TAF, so it seems to be a very, very safe strategy. A slightly higher proportion of patients suffering adverse events leading to withdrawal, and in many cases associated with CNS symptoms like anxiety, insomnia, but as one would expect, because we're now with dolutegravir 3TC, so this is not this is not a strategy that's leading to less adverse events. Anyhow, the change in serum lipids from baseline at week 48 was fine. There was not an increase, a worsening in serum lipids in the dual therapy, and again, the change in renal biomarkers was very, very minor and without possibly clinical significance. Same thing as the bone biomarkers. There was a sub-analysis of virological response by proviral M184V status, and to make a long story short, presence of M184V in proviral DNA did not change the results. Patients with proviral M184V did very well as well. So switching to dolutegravir 3TC was non-inferior to remaining on a TAF-based regimen through week 48 in antiretroviral experienced virologically suppressed adults. There were no confirmed virologic withdrawals in the dolutegravir 3TC group, zero resistance development in dolutegravir 3TC group, and the safety profile was consistent with the DTG and 3TC labels. So this is an option that will be considered. I will summarize the data from other studies, like the SWORD studies. Again, this is a little bit more older study from 2017 by Jo Maria Llibre. Again, dolutegravir or rilpivirine achieving similar virological responses to triple therapy. And a number of other studies that have been looking at the maintenance with raltegravir etravirine and the NRS, for example, also leading to similar results. And finally, the LATE and FLAIR study designs and showing that cabotegravir long-acting plus rilpivirine has similar virological outcomes as dolutegravir abacavir 3TC. In the ATLAS studies, again, very similar results, showing that these long-acting drugs might be actually very equally potent and a good option. The only worrying aspects was that virological failures with cabotegravir, long-acting, and rilpivirine were associated with some emergence of resistance, but that happened essentially in individuals infected with a subtype A1. And the FLAIR study, the 3 individuals came from Russia, and in the ATLAS study, similar findings. A1 and AG, so from Russia and France. I'm just finishing the dual therapy. Remaining questions include how would dual therapy perform in the context of TB co-treatment, adolescents, children? What are the pragmatic issues related to having patients in both 3-drug and 2-drug regimens? And how do we balance the financial impact of dual therapy with the programmatic challenges in low-resource countries? So the future will include the same of dual therapy. It includes that possibly reverse transcriptase inhibition seems to be crucial for dual therapy. We will see data coming from the Merck nucleotide inhibitor islatravir that will be very interesting as well. So it seems that the anchor drug must have high genetic barrier. Dual therapy can be safely prescribed with virologically suppressed patients with no previous failure. Now, dolutegravir 3DC is recommended as first-line antiretroviral therapy in naive patients as an option. It is also an option as a switch therapy. And that's it. So, well, thank you very much for your attention. If you can find